Can you hear me, please? It's a response someone that you can hear me. Yeah, you can hear me. Okay, Maduka says you can hear me. All right. Thank you. So maybe I should just shut down my video to see if that would help in the class. So I don't keep getting them signed out. Do I get a response? Do I have your permission to shut down my video? I don't know where you are, whether you're going there too. Or we should just go ahead and see how it goes. Hello. I like it to
You can shut down your video, man.
be an interactive class so that at least from the class. All right. Thank you for your permission. Let me try and shut it down so we don't get distracted. So sorry about this. For some reason, I don't know why of all these, and this is supposed to be a good network, Starlink. For some reason, it's just not. If it goes off again, I'll just change internet provider and hope see the spend a lot of time is for that. So we'll just go into the class. Dave, what we have for today is understanding research designs. And my name is Oyinye. Mba. I'm with the University of Port teaching them. So today we'll be going through or trying to design or study designs and meet all our objectives of the class or the training. Expect that at least we should all know how to list the different types of study designs. We should be able to classify them, know which where identify what the strengths and we identify scenarios where you use a particular study design, or in our what study designs will be most appropriate for that particular research or study. So we'll be going through like look at what are research designs, and then what are descriptive studies, analytical studies, and then we'll conclude. So, but we know that research basically it's a systematic process of collecting, analyzing, interpreting, and presenting data so that you can form an opinion about a particular or solve a problem or increase your knowledge about a particular idea or provide a solution to an existing uh, process. So there is a method to the madness of carrying out research. And one of the things you need to do is use a study design. So we ask ourselves, what are study designs? Study designs basically are scientific procedures or methods that you use that one wants to do. That research you want to do, the research questions that your study hopes to answer, the process or the design we use, scientific way that you methods or procedure that you can use to collect that specified in your objective. And the primary objective of the research design is to ensure or guarantee that questions that you have set and answer the question as clear. There are some things that decide or determine the type of study design one uses in carrying out a research, one of which is the nature of the questions. So what question are you trying? Are you trying to find out or describe what is already existing, or are you trying to test a hypothesis from what you already know? Are you trying to find reasons why the type of or the choice of study design one needs to use for a study? Also, the actually stems, it's the main thing where the question comes from. What is the goal? What's the overall aim? This is you're trying to describe a problem. And also, very importantly, the available resources that you have also help you to choose or determine the study design one wants to use to carry out their research. Available resources such as time. What amount of time do you have available? If you're doing have 3 months or less to do your research, can you do an ROCT or an intervention study that requires a longer period of time for you to test the effect of the intervention you're carrying out? If you're doing a PhD, which is a longer time, 3 years, can you do intervention? Even at that, how long? Or your PhD, there is 3 year prior, they usually know that the latency period 30 years. So the time helps you to determine the choice of the design you want to use. If you don't have time, what do you use? When you have also helps you to determine Do you have the skill to actually conduct a randomized control trial? Can you measure adequately? Do you have a lot of times people want to do a qualitative study, and we know that the skill for a qualitative study is not what everybody knows. There are very few people who have the skill to carry out. So if you're unable to do that, what do you do? So those are some of the things that will determine the choice of a study design that one wants to do. So, but before we go into the different, when we say variables, and we said already, we know that objectives are from your lab to do, and they have to be smart. So those things you set out to do have to do with your variables. What are variables? Variables are basically that varies across a study unit. For example, if you have individual participants in a study, when you measure each person over time, some examples group in that study population, sex is also a variable, things like weight are. So, and your variables, you could have your exposure or your outcome variable. Your exposure variables are your variables or your predictor variables, or that you want to expose the people to, or the intervention you want to withhold from the people. So what the outcome measure will be, you're going to that intervention, what are you going to exposure? Well, that they are the dependent variables. They depend based on the predictor that you've already know. And we say that exposure refers to things like risk factors, which whose effects maybe you're trying to study. If it's a cohort experimental study, it can actually be causative to cause that outcome variable that you're looking at. An outcome variable consequence of being exposed to that exposure or the intervention. So study designs can be classified in different ways based on if you're looking at manipulating an intervention or not, whether you're doing a manipulation or you're intervening or not. It could be classified into observational studies are those where the researcher is just documenting what is naturally occurring, between the exposure and the outcome. The researcher is not manipulating, is not intervening, is not making any active modifying anything. The things are just occurring naturally. And the researcher is just going to observe, and the studies like experiments or studies where the researcher coming to maybe a group, the intervention group, and then not performing that intervention group on the specified based on whether it is descriptive or analytical. So in a descriptive study, just as the name suggests, the main thing is that you're just the investigator or researcher is just describing the data on one or more characteristics of that group for the individuals in the group. They don't need to try to answer any question between variables. You're just plainly describing what you're seeing. And the descriptive studies generally are what initiates or brings about a hypothesis. So you could say that in a descriptive study, if you're classifying the study based on a hypothesis, the one that describes or generates a hypothesis is your descriptive study. Analytical studies, on the other hand, are the studies that you use to test a hypothesis that's been established already. A hypothesis that has been put forward, be used to actually establish whether there's a causal relationship between variables. It can be used to check the effect of an exposure or intervention to an outcome. So it's an analytical study uses to test your hypothesis. And then sometimes you can classify study designs based on the directionality of that study. So it could be a retrospective study or a prospective study. Prospective study is that study design whereby the researcher is looking back in time from where they are. From the beginning of the study, you're following them up to find out if they develop the outcome of measure that the researcher is interested in. So that's basically how you can classify your study design. So using that, the characteristic analytical, where you're testing a hypothesis or you're trying to find the causal relationship or the relationship that exists between two variables. We have broadly the descriptive studies and the analytical group. In the descriptive study, you have that is further divided into whether it's individual study or a population study. In a in individual study, you're looking at things like the case reports or the case series, or you're looking at a cross-sectional study. While when you're looking at the population at the population level, you have the correlational study or the ecological studies. On the other hand, you have the analytical group. Under the analytical group, you could have the study, the case control, and the cohort. So cross-sectional study could be descriptive. It could also be analytical, depending on the research question that you're trying. Observational studies are things like the case control, cohorts. And then in the cohort study, you have the prospective, in which you follow people up from where the researcher is to follow them up down outcome of interest. While in retrospective study, the researcher is, or the outcome and exposure have occurred. So what's happened with the exposure, how is it related? Intervention study. The intervention studies could either be the randomized control trial or the non-randomized control trial. So we'll deal with them when we're the different study design based on their classification. This classification also provides an evidence of, shows you the hierarchy of the scientific evidence that each of these studies bring series, which are the weakest, that provide the weakest scientific evidence. And we know it's a descriptive study. And then from there, you now progress to things like the case series, the cross-sectional study, randomized control study, and then the highest hierarchy of evidence, systematic review. We won't be talking about meta-analysis and systematic review in this, because in the real sense, they're just meta-analysis and systematic review are dealing with studies that have already been conducted. So they are secondary data study, you're pulling out studies that have been synthesizing the information to be able to answer a research question. And we know that in systematic reviews, you're just pulling these studies and then you're finding out what they have in common, trying to answer your question. The difference between meta-analysis and systematic, maybe in a systematic, you put like 20 studies or 30 studies that we have reviewed together. In meta-analysis, you're required to collect them together and run results. That's basically, so we'll know that depending also on the, so help you determine which study design you want to use on that. So going to now talk about them individually, we've talked about, say, the descriptive studies are there. So what are descriptive studies? Descriptive, as I've already explained some of it, or can someone can just unmute and just what you think? So sorry about that. I've changed my internet provider. Hopefully, this one is better. So sorry. Can you hear me now?
Yes, ma'am, we
Hello.
can hear you.
Okay. All right. Thank you. So let's just, sorry about that. For some reason, the internet is not my friend today. So descriptive studies, that's where we stopped. Descriptive studies basically are the first step in understanding is understanding a given community health or a disease problem, because you're just describing what you're seeing. In describing what you're seeing, you're able to now find out that, oh, this is what they have, this is what they don't have, this is what is prevalent here, these are how many males they have, adults are this and all that. So descriptive study basically just, it describes the amount in terms of frequency or magnitude, or how the things are disease also being distributed in terms of person, place, and time. How many people are being affected? What age group is most affected? Which area? Is this something that happens more in the urban area than in the rural area, or in the northern part of that place than in the southern parts? And what particular time is this something that is seasonal, something that happens during during rainy season, or something that happens during dry seasons, or in the places where they have summer and autumn? Is this something that is time dependent? So it just describes the amount and the way that disease is being distributed without attempting to actually find any relationship between the exposure and the outcome, or the cause and the outcome. It just basically describes what is going on. So you have a case or cases of something, let's say in River State, and you want to pick up things like maybe a disease like diabetes. So you want to find, oh, who is affected? First of all, what is the case? What amount in terms of what's the prevalence of diabetes? Who are the people that are affected? Is it the adults? Is it the children? We want to find out the place. Is it something that is commoner in a particular area in River State or not? And then in terms of time, is it time dependent? Is it something that, but most times those are usually things that have to do with the communicable diseases. So the descriptive study basically just answers you what the health issue is, who is affected, where the place is, and the time of where the disease is high, or when the disease is higher. So the objectives of a descriptive study really is to provide data regarding the size or the magnitude of that disease. And that's what we call the prevalence of a disease. That's what a descriptive study does for you. And a descriptive study also helps you to provide clues to the disease etiology. You might just be able to, because at the end of the day, you might be able to say, oh, this thing seems to be more among the old people than the young people. Is this something that must have started when they were old due to the exposure, when they were younger, exposure that over time this disease now happens? So it gives you a clue, but you can't test, or you can't for sure say that this thing or the exposure will definitely cause the outcome. It also provides information or evaluates the trend in that in health and compares it with other groups. So if you do a descriptive study of in River State, you can look at the prevalence of a particular disease in the different LGAs or in the different age groups, and then you can do that. You can also do that over time. So you can look at prevalence of diabetes in River State, maybe a 10-year review. So you've looked at what it is. What does it look like? Is it increasing? Is it reducing? Or is plateauing? There's no change. It helps you, the information you gather, because it describes the population. It describes who is affected more. It describes which area is more affected. So because you have this information from a descriptive study, it can help you to plan and evaluate services. So you plan if the thing is more in a particular LGA, then you will need to channel your intervention and focus in that area. If it is something that is a particular age group, let's say under 5, you need to know how to plan and reach and provide an intervention or services that will address that problem. And lastly, which is very important, is the research study helps you to generate a hypothesis. So on its own, you cannot test a hypothesis with a descriptive study. You just, at the end of the day, you can say that, oh, diabetes is prevalent among old people because there's a relationship that, so because of that, an analytical study might now want to take up is that hypothesis that you have generated, and I said, oh, we want to find out that really, does age have anything to do with diabetes, or does sex have anything to do? So it generates a hypothesis, which an analytical study, depending on whichever one we choose to use, will now be used to subject that hypothesis to a test to see whether the hypothesis is true or not. So in as much as the evidence on the hierarchy, it's not that high, it still has some advantages. It's quick and it helps, you can generate information very fast. So when you also have limited resources in terms of fund, it's easy for you to do a descriptive study, because you're really just not spending, so all you're asking people and describing what you're seeing, so it's not expensive, and at the end it helps you to generate hypotheses in from that study. The disadvantage, like I said, it has a very weak strength of evidence, because there are a lot of things that could be used to explain what you're seeing. So until you subject that hypothesis to a test, you cannot say that. And then because we know that in a descriptive study, the exposure and the outcome measures have occurred, and you're collecting the information simultaneously. You're collecting the information at the same time. So you cannot adequately say that the exposure would lead to an outcome because it lacks temporality, meaning you don't know if the exposure occurred before the outcome, because the outcome may have occurred before the exposure. And we know that one of the criteria for testing causality by Bradford Hill is that there's temporality. So the exposure must occur before the outcome measure. So because we don't have that in a descriptive study, we cannot answer that causality or cause effect question. So those are the advantages and some of the disadvantages. So now going to the descriptive studies in details, the first one is your case reports or your case series. Your case reports basically consist of collecting informations or reports on an individual with a certain condition. So there's a one person or one subject. You're collecting information on that subject. And the information, because it's just one person, you're collecting detailed information from when the thing started, before it started, information about the person, the kind of if it's a disease, when did the symptoms start, when did they notice what, how did it progress. So whenever you're collecting that information about one individual or one subject, it's called the case report. And then when you have a lot of case reports, pull it together, 5, 4, you get your more than one case report, you now have what we know as the case series. And in as much as they are weak in terms of the scientific evidence that they provide, they are equally very important. One of the typical example of case report or case series was in the 1980-81 when HIV/AIDS was first identified. So there was a disease, it was used for when they noticed that a lot of men, homosexual men having sex with men, came down with pneumocystic carinae. So it was from studying one HIV man who had that, they reported what happened when it started, and then they used that to, and because you collect detailed information about that one or few people, you can use that to understand the general history of a disease. So when it's one case you're looking at, it's called a case report. When it is one more than one case put together of the same condition that you're checking, it's called a case series. So it consists the collection of treatment of an individual. And in a case series of case reports, they have its strengths and its limitation. One of the strengths is because it can be used for educational purposes, like where you use it to teach people what, at least they know what case report and case series are. And then you also use it to understand the disease progression of a particular disease. So because of that, you can use it to teach people about how that disease, when it started, emerged, how it progresses, the likely symptoms, and then what happens at the end. It can also be used to, generate a hypothesis. So when you've looked at a lot of case series of HIV men who had came down with pneumocystic carinae. So they came up with that hypothesis that like pneumocystic carinae, most likely it's because it's commoner amongst people who have HIV AIDS. Most likely it might be an opportunistic infection or something that is closely related to HIV infection or AIDS. So that hypothesis now is what an analytical study will go and check to now find out that whether really is that the case or not. It can be used for researching very rare disorders like emerging diseases or something that just came out and we don't really know about it, because it helps you to understand the disease progression. You can use case report or case study to research very rare diseases. I want to understand how it comes about, how it manifests, how eventually it manifests in an individual at the end, produce something that can lead to death, or something that the body is able to resolve. It provides you an in-depth narrative of cases because you're studying you can imagine when you take one person and you study, the age, how old they are, their sex, their socioeconomic status, things about them, the way they live their life, and then from how the diseases and the things, how that disease started, you're able to understand and narrate exactly how that case is. It's also flexible because it's just one person at a time. Most times is when you just see the case, you collect the informations. And some of the limitations are because it's just something you did in an individual in case of a case report or in case series, a few people, you didn't calculate sample size. So that result is not exactly valid. So you cannot generalize it to that result lacks generalizability. It cannot be inferred to the general population because a sample size was not calculated. They also don't have control group. They say no control group, no conclusion. So because there's no control group, you can't do a valid statistical test that you can infer to the general population. There are no epidemiological parameters too. Because you say you're doing an in-depth narrative of a case, there's a tendency to over-interpret everything that you see. So when that's because of that over-interpretation, because you're analyzing everything you see in that individual. In another person, it might not play out like that. So that is a limitation for case reports or case series. There are also confidentiality issues because you're really asking some very personal questions, information from an individual. And then, although when you're reporting it, you will just say Mr. A is so, but if you have to include the person's age, occupation, where they live and all that, someone might be able to hazard a guess who you're talking about. So he has issues with confidentiality. And like I said earlier, it's very low in the hierarchy of hierarchy of evidence. Then we look at the ecological study. What are ecological studies? Ecological studies are basically studies in which the unit of observation is a group. So it's not a separate individual. It's a group of people that you're studying, you're looking at variable in that group. For example, if you're looking at exposure and risk factors that are known only at a group level, such as things like if you're checking the average air pollution concentration in different countries, or you're looking at countries with prevalence of colorectal cancer of the colon with relationship with the meat consumption in a particular country. So they are population-based studies, and it's not the individuals. You just use data that already been collected about that information. You're not going one-on-one to ask people things about themselves. Ecological studies, usually it helps you to explore the association between the exposure and outcome in a population at a population level. It looks at the relationship between that outcome of interest in that population and how it's related to the exposure estimates. So it deals with communities, it deals with a like River State, Nigeria, can be a geographical place, and not the individuals in River State. Often it's used to measure prevalence because you can easily, from statistics and all that data collected, what the total population is of that area, and then the number of people who have say diabetes or who have colorectal cancer, and then you're able to get the prevalence of colorectal cancer or prevalence of the quantity of meat that is being consumed in that area. So it's used to measure prevalence and incidence of diseases, especially when the disease is rare. So you're able to pick up from register, maybe cancer register, these are the number of people who died from this particular thing. And then those population results can be compared with the different others. So you can compare population with data with another area. You can compare River State with Bayelsa. You can compare Nigeria with Ghana, or developing countries versus non-developing country. So you have, like, I know that the proportion of pap smear or prevalence of pap smear that is being done in let's say in Nigeria, and then the mortality due to cancer of the cervix, and you want to look at it and see whether there is a relationship with the thing. But unfortunately, if the study shows that there's a high rate of, let's say, if you're looking at coronary heart disease and per capita cigarette smoking, or per capita of fast food, even if the study says that there's higher rates of heart disease in a particular region, then that same region still has higher consumption rates. It cannot, the result from an ecological study cannot be used on the individual level. When you do that, you commit a fallacy that we call ecological fallacy. So the results are presented upon a population level rather than individual. But those information that you've collected, you do not have enough information for you to be able to say that, yes, that particular, since it is high, that means it can also apply to the individual. Like the example I give about coronary heart disease and per capita cigarette smoking. So because both of them are high, the number of people that smoke in let's say Nigeria is high, and a lot of people also come down, and the prevalence of coronary heart disease is high in Nigeria. I cannot now not say that everybody who smokes is going to end up having coronary heart disease. That's what we're trying to say. If you do that, you would have committed an ecological fallacy. So basically, it should be considered that we know that is at the population level, and population those studies do not provide information to the degree that that outcome of interest would be used for individuals when you're analyzing it. What are the advantages or strengths and weaknesses of a correlational study or ecological study? Correlational studies are the same as ecological study. So their strengths, because they are quick, and their population studies, those data are already there. You just already know how many people are in this place. From data, you can collect, oh, this is the number of people, maybe cancer register, who has colorectal cancer or CA cervix, as the case may be. And then you're able to conduct study at that population level. It helps you, it describes the strength of relationship. Yes, it can tell you that, yes, most likely, since this exposure is higher, they might be related, because that's what makes it a descriptive study. You're not able to test that hypothesis. You have to conduct that study, which will now require you to collect information on individual basis and say that, yes, these two things are related in this manner or not. They can be used as behaviors, and they provide, yes, you can have predictors. You cannot have predictor variables, or you can manipulate it, because it's a descriptive study. We know that you cannot manipulate it, which you have in intervention studies. And then because you easily use data that have been recorded, so it makes it easy for you to use. The disadvantage or limitation is that correlational studies do not equal to causality. Remember, we also say you're collecting the information for both exposure and outcome simultaneously. So you cannot determine or categorically say that the exposure will lead to an outcome. And correlational studies can be misused, just like we said, in terms of that ecological fallacy, since you cannot infer that in the individual. So you cannot just say, because this is high in this community and all that, that means everybody who smokes must come down with cancer of the lungs, as the case may be. It cannot provide you certain information that you need in the individual measurements when you're trying to do that analysis. Then we progress to the next study design is a cross-sectional study. A cross-sectional study is also studies, and it's also known as prevalence study. It gives you, or the investigator is taking a snapshot of the exposure and the outcome. So it describes the disease, the burden, the trends, and it's collecting the information simultaneously, and it examines the association and exposure at a point in time. So you can't really make out much about it. It can be analytical. Remember, I said you have a cross-sectional studies that can be analytical or descriptive, because by the time you start checking predictors and then descriptive studies, and these, when you start checking associations that are guided by your hypothesis, especially for those of you who are doing masters, and then maybe your number 1, 2, 3 objectives, you're measuring a particular outcome, and then the last one or one objective is looking at factors that are associated with the outcome you're measuring. What are the determinants of hypertension, or determinants of or predictors of diabetes amongst the elderly? At that point in time, it's no longer a purely descriptive outcome, is done simultaneously, and you can't prove causation. So what are the characteristics of a cross-sectional study? It is simple, it is easy, it is cheap to do. You're not making any manipulation, you're not providing any intervention, you're just describing what you see. It can tend to have recall bias, because you're asking people questions about things that may have happened a long time ago. So they may not be able to remember it very well, or the degree to which they remember might be different. It provides you with a hypothesis. So it helps to generate a hypothesis. And you don't really need to be highly skilled to conduct a cross-sectional study. And even though you don't need to be highly skilled, one of the demerits is that we've said that it cannot be used to test establish test causality, because it lacks temporality. It is used for planning, because you know that it describes what you're seeing in terms of the amounts, the size, the people who are affected, the place and time. Organizations and the governments can use those informations to plan, and then using them also allocate resources and interventions that can be used to address to existing problem. The strengths of cross-sectional studies stem from the fact that because it's inexpensive, it is cheap, and it's cheaper. And then you can also do it, something that can be conducted, is less time consuming. You also use a cross-sectional study to monitor events, do your M&E. So if you're doing an intervention study, or you're providing an intervention, or you're providing a particular service, the cross-sectional study that you can use to monitor intermittently, you're checking to see how far the progress of how is it progressing with the outcome measures, the objectives that you set out, your indicators that you're measuring, are they going the way you expected them to go? The cross-sectional study can be used to do that. And it has little or no ethical issues, because you're not making any manipulation. You're not just watching people. So there's little to the most risk most time is just that questions. People may feel uncomfortable with certain questions that you may ask them about their lives. Some people don't really like discussing things like if it is sexual based or thanks to their finances. People might be uneasy, but outside that, it really doesn't have any major ethical issues where maybe you want to collect blood or bring a new drug, or as the case may be. So because the cross-sectional, it's easy, it's stable, you're collecting information both the exposure and outcome measure at the same time. You can collect multiple outcomes. In a cross-sectional study, you can do both prevalence of diabetes, hypertension, and coronary heart disease, and all sorts. So you can collect multiple outcomes as you're doing a sectional study, and you can estimate prevalence of all those diseases of interest or outcome of interest that one wants to do. And odds ratio can be estimated, particularly when you're doing the logistic regression, which is the parts looking at the factors or determinants of a particular disease or outcome measure. The limitation is that because it lacks temporality, you can't test or derive a causal relationship. Is prone to bias. People might not remember. There's social desirability bias, and the response rates can also be minimal. It does not demarcate between exposure and outcome measures. So that's why sometimes some school of thoughts believe, like, if you're doing a study where you're doing an intervention, sorry, not intervention, you're doing you're assessing factors or determinants or predictors. Some will now tell you that a lot of times the students will write they are doing a descriptive cross-sectional study. So it's advised that there's no point trying to qualify, but you can just write it, report it, or study design. You're doing a cross-sectional study that covers for both the descriptive parts and the analytical parts. And then if you say you're doing analytical cross-sectional study and you're not exactly, there's some things, some people don't agree that just those things are your simple cross-sectional study. So you're safer to just write you're doing a cross analysis, that you should put those qualifiers which are not really needed. Well, you can go ahead and do that. So that brings us to analytical studies, the other arm of study designs, analytical studies. Analytical studies basically are the second major type of epidemiological studies after descriptive studies. So you know that when you have described something, you generate hypotheses. Then analytical studies comes to now what? Take over and now test those associations. It's a systematic determination of disease association between exposure and non-exposure. So now you want to find out, basically, most analytical, because for you to say your analytical studies, most times you have your two groups, the control group and then those who have the disease and those who don't have the disease. So that some say if you don't have a control, you cannot make a conclusion. So the subject of interest is at this point within the population, as opposed to what you have in the ecological study when they're looking at the population level. And the objective of doing an analytical study is that you want to test a hypothesis. So in those studies where you have determinants, you can have hypothesis that only addresses that part of your objectives. But if you're doing a purely descriptive study, as in you're doing a cross-sectional study without looking at the factors associated with it, that study shouldn't have a hypothesis. What you should have is at the end of the day, you would generate a hypothesis. But if it's an analytical study, or there's some elements of or one or two of the objectives are looking at testing a hypothesis, then that makes it good. So inference, the beautiful thing about an analytical study is that when you finish, you can make an inference from that sample that you have, from the results, or from that your sample, you can make the inference to the general population from which that individual was selected. And there are different types of analytical studies. Like we said, there are some that are observational, the ones that are observational, the ones that are intervention, we'll also talk about them further down the line. So the observational ones, based on the subjects you have selected, whether they have exposure stat, whether they are exposed to the disease, whether it's they're exposed to the disease or they're exposed to the exposure. So you have the case control studies. In case control studies, the subjects are selected based on their disease outcome. You're looking at those who have the disease, and you're going out, and then those who don't have the disease, you're going to check behind before whether those the exposure, whether the those who are exposed to the factor that can cause that thing or that can lead to the outcome is higher among those. Unlike in a case cohort study, the subjects are selected based on exposure status. So you select those who are exposed to the factor, or they exposed to that factor you want to look at, and then the controls won't have that, and then you follow them up to find out whether they will end up having that disease. Then you have the cross-sectional study. In this cross-sectional study, I'm looking at where you have the comparative cross-sectional study. There are two groups. So you're comparing between group 1 and group 2. You're looking at some factors and you want to find out. You're looking at there's a difference between group A and group B, urban and rural, this state and that state. If the knowledge is higher or prevalence is higher, what could be responsible for that? Or you're looking at the relationship between two variables in a particular group of people. That's why you have your cross-sectional study. So in both cases, both designs, or you're measuring the presence of a statistical association, and you want to check the strength of that observation. So in measuring the statistical association, in a case control study, what you use is the odds ratio. So you want to determine whether the odds of getting the disease is higher among those who were exposed as opposed to those who were not exposed to that factor. While for the case cohort study, you're looking at the risk of developing those who were exposed to that factor compared to the risk of developing it among those who were not exposed. So at the end of the day, you have the odds ratio for case control and your relative risk for cohort study. And the interpretations basically based on what your cohort is. So looking at the cross-sectional study that is analytical, you're still looking at the snapshot design, but you have two groups based on that exposure. So some people in the two groups that you're looking at, so you're comparing the two groups, and then the exposure and the outcome happens simultaneously. You're collecting that, you're measuring that thing, not that they happen, they're measuring it at the same time, which is what makes it a cross-sectional, a snapshot. And sometimes you can have a hybrid of cross-sectional analytical, which is what I was talking about when you're looking at determinants, predictors of a particular disease in a cross-sectional study. What are the strengths? In a cross-sectional study, we know that they are cheap, they are easy. It's easy for people to do that. It does not waste time. It requires relatively fewer subjects. Your sample size will be smaller. And then you can assess multiple exposures. There's minimal risk to the subjects, and you can estimate ratio and adjust estimation. And there's nothing like loss to follow up because you're collecting everything at the same time. There's also the period cross-sectional study. When you're collecting the information is over a period of time. Prevalence of diabetes in the last 2 years, in the last 5 years, it was a cross-sectional study. The is that it's difficult to derive causal relationship, like you said. You cannot measure incidence because both exposure and outcome have already happened, and it lacks temporality. So the other analytical studies is the case control. What's a case control study? The case control is your first step in your testing. And in a case control study, both the exposure and the outcome have occurred at the start of the study. When the investigator or researcher, like what you have in cross-sectional study. But what now happens is that the study now progresses from the disease to the cause. So you have the cases, those who have that disease. Then you now have control, those who don't have that disease. And those are your two comparable groups. So you now go back, and you're having those two comparable groups, you need to ensure that those two groups are comparable in terms of factors that can affect the outcome measures. Because if you don't compare them, sorry, if they're not comparable, then the results you're finding might be due to confounders or confounding factors. So basically, you want to do what we call matching. So in a case control, you have the disease, those who have the disease, and then those who don't have the disease. Then you now ask them questions. You're going back in time to find out, among those who have the disease, how many of them were exposed to that exposure, that factor, that's exposure factor. How many of those who are controls, that's who don't have the disease, you still want to find out how many of them are exposed to that particular disease or not. Looking at this diagram, when you're looking at a case control study, you have your cases, people with the disease, then control, people without the disease. Then you're going back to ask them, among these people who have the disease, some of them may have been exposed to that factor of interest. Some of them, like if you're looking at what they call cancer, maybe CA of the lungs. So you find those who have cancer of the lungs, find those who don't have cancer of the lungs. Then among those who have cancer of the lungs, what maybe exposure factor you're looking at is cigarette smoking. So you want to find out how many of them were smokers and how many of them were not smokers. Because you will definitely have some cases, some people who have cancer of the lungs who never smoked. Then you also go the same way, ask them about the control. Find out among the control, those who don't have cancer of the lungs. You will have some people who smoke, but they don't have cancer of the lungs. Then you have some people who don't smoke and still don't have. So the question, the direction of the question you're asking, you're going back in time to find out, to make analysis is higher among those who were exposed as opposed to who were not exposed. And then when you select your cases, you select your controls, and your controls must match your cases. So you want, especially if something like sex can be a confounder in a particular disease condition, then you make, what the matching means is that if you have among the smokers, if you have, let's say the sample size is 100 among those who have cancer of the lungs, you have 50 males and 50 females. In selecting your control, you also have to make sure you have 50 females and 50 males who do not have cancer of the lungs. So you're matching for the sex. If it is age, that age can confound. You know that age there's a relationship between age and cancer of the lungs. So you want to make sure that if you're using people who are elderly, then your control will also be elderly people. That's what matching. We'll talk about that somewhere else. So you must, and then when you have matched your cases and your control, you must measure the exposure among the cases. And so you can exposure only among those who have cancer of the lungs. You have to measure the exposure in those who have that cancer of the lungs and measure it in those, may control those who don't have. Then you make your analysis and then interpret your results. So how do you select your cases? In selecting of cases, you must have beforehand determined what your diagnostic criteria would be, or how will you decide that somebody has cancer of the lungs? How do you make that diagnosis? You must state it before time. It's not something you do while you have started the study. Then you must decide who is an incident case, who is a prevalent case, who will you add, who can you say that has who has cancer of the lungs, and then if you're matching with ages, what age group, what sex, you must decide all that before you start your study. And where can you get your cases from? There are different places cases can be gotten from. Like I said, your cases must be predetermined. And then in getting your cases, you can get cases from hospital. For convenient cases and completion of records, most times we prefer that you get your cases from hospital setting or a physical physician practice or disease registry. So there, you know that yes, you will get, if you go to the hospital, say, okay, you want data, information on all those who have cancer of the lungs. You can get that from a hospital. It's convenient. Most times the records are accurate and easy to assess those cases. You can also get your cases from general population. You can decide to go into the general population, make a diagnosis, do a survey, get those who have cancer of the lungs, then get a control and follow. You can also get it from a registry, death registry. Like you have all those cancer registry. But for you to do that, if the registry must have the cause of death. So because you could have someone who has cancer of the lungs, but died of accident. So it's not the cancer of the lung that is the cause of death. So what if you decide to get it from a registry? They must have the real cause of death so that you know that it's ascribed to that disease. Then you can get cases too from when a cohort study is being conducted. In a cohort study, okay, we haven't talked about a cohort study. You're following them up in time to see those who have developed. So as they follow them and someone develops cancer of the lungs, you can take the person becomes a case, and then you get a control for that person. So basically, you have to decide whether I want to use newly diagnosed persons, those are the incident cases, or you want to use prevalent cases, those who have both old and new are prevalent cases. It must include your inclusion and exclusion criteria, which must be clearly spelled out or clearly defined, because this will improve the validity of your results. If you don't spell it out, the validity of your results might be affected. Now, where do you get your controls from? You can remember the main thing that makes one to be in a control group is that you don't have that disease of interest. That thing that you're looking at, they don't have it. But so first of all, they must not have that disease, but they must have similar opportunities for exposure to that case. And they must be similar to the cases, except for that. So if you have those who have cancer, those who have cancer of the lungs, you can decide to use control measures to be those who don't have cancer of the lungs. They might have any other disease, but not cancer of the lungs. It doesn't necessarily mean that you can. So where do you get your controls from for your control? So you can also get a hospital control. So if you have cases in the hospital who have cancer of the lungs, you can decide in that same hospital, you want to get those who don't have cancer of the lungs. And in that hospital, for hospital control, it can be in the same hospital, but they might have a different disease. And remember, your controls must also undergo that diagnostic workup. That way you used to make the diagnosis or take a decision that someone has a disease must be used to determine that that particular person, another person, doesn't have that disease. So there are other sources, other places where you can get your controls from, apart from the hospital. Controls can also be relative. So in a family where one person has cancer of the lungs, you want to get another person in that family who doesn't have cancer of the lungs. It might be extended family, it might be. Controls can also be neighborhood controls, those who live in the same area, particularly if you're looking at because when you do that, people who live in the same area are exposed to similar things. So most times nature has kind of helped you match certain criteria in those groups. You can also get from a general population. When you're doing general population means you can have controls, cases in the hospital, but in the general population, you can get your controls and they can be used. It's also important to note that in getting controls, you get up to as far as 3 or 4 control. What it means is there's a ratio in which you do cases and control. If it is 1:1, it means if you have 50 cases, you must get 50 controls. You could have cases where you can use 1:2. So you have for every one case, you have 2 controls that are matched towards that. Okay, so depending on your sample size and your funding, because we know that if you use more than one, obviously you will increase your sample size, and then it will increase, you will need more funds to do that. And the teaching is usually in fact, beyond 4 controls, the value we get in using more than 4 controls, it's not, you're not gaining anything more by using 5:1 or 6:1. And then you're obviously going to use a lot of resources and time consuming, because sample size will be jacked up, So there's actually at the first time, between when you're doing 1:1 and when you're doing go from 1:1 to 1:2, there's actually an improvement in the results you will get. There's actually benefits. By the time you get to 3 and 4, the graph actually starts plateauing, showing you that the benefit you're going to get from increasing the number of control does not really match the costs or the things it will take you to do that study. The results will still equally be valid when you do 1:2 or 1:1, so far you properly match them. And I've been talking about matching for a while. I said, what is matching? You use that to make sure that both your group, the cases and the controls are similar. You must use that to make sure that they are comparable. And matching is actually a process whereby you're selecting controls so that they are closely related to the cases about some pre-selected variables or characteristics that would influence or confound that outcome measure or the disease that you're looking at. So that's what matching basically is. So you just want to make sure that the two groups are comparable, because if they're not comparable, if you find any significant difference in the two groups, that significant difference might be due to those factors you did not match. That's why. So if you do a study and you use more males than females, maybe in the cases, you have more males, and then in the control, there are fewer males. And at the end of the day, you now say that, that this disease is commoner amongst the males than you have in the females. It might not be true, because you didn't look at more male. Your study looked at the majority of people in your study were males. So you can't make that conclusion, because whatever it is that you're seeing might be due to the fact that more males were enrolled in your study or were among your cases. That's what matching usually does. So how do you do matching? Basically, in doing matching can be done on a group basis, or it can be done on an individual basis. In a group basis, you're assigning cases to a particular subgroup based on their characteristics. So you're looking at male and female, or age under 5, and then under 5 or 50, or women of reproductive age group, which are women between 15 and 49. And then you're matching like that. So it's a group matching. So you're selecting appropriate controls based on that subgroup, women of reproductive age group. And then the frequency of the distribution between the matched variables must be similar among your cases. So if it's a whole population study and you say that, 10% will be under 5, 15% will be adolescent, 20% will be young people, then you have young adults, then all that. It should be the same thing in your control. So that's what matching is. You cannot at the group level. You can also do matching at individual level. So meaning for each case, you must match. So if assuming you want to you've included a 40-year-old doctor that have a particular maybe cancer of the lungs, and then you have to match with another 40-year-old doctor who does not have cancer of the lungs. So you're matching individuals individually. This can be usually more tasking. And you can also match things like duration of illness. So those who have had hypertension for 10 years, you match. The controls will also be those for 10 years they've not had. So depending on severity you can match based on any parameter of interest that has the ability to influence the outcome measure or the results, the hypothesis that you're trying to check. But we have to be careful when we're doing individual matching, because the tendency to be overzealous in matching can actually reduce the association that exists. So when you overmatch, you probably may not be able to find out so it's something that has to be done. You have to look at what you're looking at and then be done with care. How do you measure exposure? We've been talking about take the measurement. When you get cases and control, then you go back and measure the exposure. For you to measure exposure, you must use the same method that you use to measure exposure in cases, and also use that same method to do control. A typical example is maybe you're doing malaria, something about malaria. You want to determine if age has an effect on malaria or something. So you've selected those who have malaria, and then you have control who don't have malaria. And then you want to go back and check paracetamol. You cannot use RDT to measure one side and use microscopy to measure the other side. No, you must use the same measurement for both cases and control. And the measurements must be precise and accurate using your case, your definition and the criteria to include people into both cases and control. And they measure the exposure. Then the methods for obtaining that information. You can measure exposure by actually conducting an interview, asking them questions. Oh, did you ever smoke? For how long did you smoke? As the case may be. It can be an interview. It can be a questionnaire, interview administered questionnaire, or it can be a self-administered questionnaire. Ask them how many sticks of cigarette they take in a day, how many years they've smoked and all that. It could be from the record, hospital record or employment record. Those are places where you can get your controls, your measurements, or assess exposure variables. So in deciding a case control or interpreting your case control, like I said, you would, at the end of the day, the statistical association you're doing is the odds ratio. You're trying to determine your odds ratio. How do you determine your odds ratio? So in a case control, on the column, you have your cases and then the control, while on the row, you have your exposed and those that are not exposed. So you should be able to get the odds of the disease among the exposed over the odds of the disease among the odds of not having among the control. So A is those who have the disease, and at the same time, they were exposed to that exposure of interest. So at the AC is the total number of people who have that disease. If you're looking at cancer of the lungs, so the total number of people who have cancer of the lungs is A plus C. Now, A is those who smoked. B are those who did not, who never smoked. So for you to get these odds is A over C. So among number of those who have cancer of the lungs, who have smoked, over those who did not smoke and they still have cancer of the lungs. And then the control is B over D. So eventually, when you do AB, A over A plus C divided by the odds of the disease among the exposed over that in the control will what to give you your odds ratio. And when you finish, if you do for those who did mathematics, your cross tabulation, your odds ratio would actually be the people in the cell A times D divided by B and C. So depending on what you get. So you could have the disease to be, cases might be those who have cancer of the lungs or myocardial infarction, and then exposure could be those who smoked, or it could be those who were exposed to oral contraceptive. So by the time you get your odds ratio, if your odds ratio is 0, it means that there's no association between smoking and lung cancer or use of oral contraceptives and myocardial infarction. But if your odds ratio is greater than 1, when you finish the mathematics, it tells you that the odds of the disease is high among those who are exposed. So those who are exposed to this, who were smokers are more likely to have are more likely to have cancer of the lungs. And the higher your odds ratio, the stronger the strength of association. Then if it is less than 1, it means that that factor actually is protective. So if your odds ratio is less than 1, usually you see this in things like immunization and all that, telling you that that thing you're checking, that intervention, you actually protects people from having that disease. So what are the strengths and weaknesses of case control studies? One of the strengths is that it is relatively easy, and then it requires fewer subjects, and is very useful when you're looking at rare cases, because you know that rare cases is difficult to find them. So if you're able to get rare cases, then get a control, then check back in time to find out if the exposure. And then because you are going back in time, you can actually assess more exposure factors. You can study multiple exposures. And you can look at both, in as much as you're looking at those who smoke, maybe smokers, you can look at the age, you can look at the influence of other diseases, maybe sex and all that. Those factors, other exposures can also be looked at, things that can actually affect the disease. And then there's minimal risk to the subject because you're not doing any intervention. You're just asking them questions besides diseases that have already occurred. And it provides you with an odds ratio, which gives you a risk estimate, because we know that an odds ratio is equivalent to a relative risk in a cohort study. You don't have any issues with loss to follow up because you're collecting your information, you're meeting them, and then you're just asking questions, you're not following them up over time. The difficulty or the limitation is that because exposure and outcome measure have already occurred, it lacks temporality, so you cannot test causality or prove causality or causal relationship. There's also an issue with recall bias. People may not even remember, or the people who have the disease, have cancer of the lungs, will remember more about their smoking than the control, because they don't really have any, so they will have issues with that recall bias. There may also be difficulty in selecting appropriate controls, because we don't have appropriate control, then the results of the findings would not be very valid. And you cannot measure incidence in a case control study. And so you have to also collect control for selection bias. Then the cohort study. The cohort study is also a type of analytical study. In a cohort study, a cohort basically is a group of people who share a common interest or experience within a particular period of time. So you can have a cohort of people who were born, today is 17th of May. So you can say all the people who were born on the 17th of May, 2029, that's a cohort. You can decide to say all the people who were born in May, that's a cohort. It can be pregnant women, the cohort. They must have a common characteristics or interest, or children who are under 5 years, or men who have HIV, or women, or widows, or, any group of people who have something in common. They are known as what? A cohort. And they can be people who are living together or working in a particular place together, or maybe they were exposed to a particular intervention at the same time, like during the time when we were giving, during the time when COVID started giving COVID vaccine. So maybe the first set of people who were given the vaccine can be considered as one cohort. So basically, that's what a cohort means. So in a cohort study, what happens is that you identify, they are identified before the diseases occur. They are identified based on their exposure status, unlike in case control, where the identification is first based on the disease status. So the cohort, you identify the people based on their exposure status. They are not supposed to have had the disease. So you have those who are exposed to the factor of interest. You find the control group, those who are not exposed to that factor in interest. And then you follow them up over a period of time to now determine among those who were exposed, how what proportion of them will come down with the disease. Among those who were not exposed, what proportion would also come down with disease. And because this is actually showing you temporality, it's showing you that exposure must occur before the outcome, then it can be used to test cause and effect. So when you're starting the study for a cohort study, they do not have the disease or outcome of interest. Both groups don't have it. Just one group are exposed to the factor of interest, the other group are not. Then you follow them up to determine if they come down with that. So for you to do a cohort study, the cohort, the groups must be free of that disease that you're studying. Assuming you are doing a cohort study of those who have cancer of the lungs. Now, although this time it's not cancer of the lungs, you're doing a cohort study of those who smoke and those who do not smoke. So your group, one group is those who smoke, another group are those who don't smoke. Then you now have to follow them over time. But remember, both the study group and the comparison group must be equally susceptible to that disease under condition. So they must be equally susceptible, but they will not be exposed to that factor. That only one group is exposed to that factor. And both groups must be comparable, just like what you have in case control. So they must be comparable in all possible factors that may influence the outcome of that disease or the occurrence of that disease happening. And then in making the diagnosis and criteria, just like what you had with case control, you must have a diagnostic and eligibility criteria for the disease beforehand. So as you're following the people up, you must have stated this and this and this will be done. And if you have this, then you'll be tempted to have that disease. If you don't have, then so you follow the people up and then measure it. Looking at this diagram, looking at it will help us to understand it more. At the start of cohort, this is a study. This study is actually looking at nurses who it wants to investigate exposure to high body mass index, so body mass index, those who are obese compared to those who are not obese. And they want to follow them, the nurses, up to find out if they would, and those who ended up with having cancer or cardiovascular disease. So the risk factors that you're looking at is body mass index or weight. So you have those who are obese and those who are lean. So at the beginning of the study, you can see this man with the bats. That's the start of the study. Nobody has the disease. You just have one group where the nurses are obese, another group where you have nurses who are lean, and then you follow them over time. And then compare the incidence. You know, the incidence means the number of those who come with the disease over those who don't have the disease. So among the group, obese group, you have to find the number of those who had cancer or CVD over the total population of people who are obese in that group. That will give you the incidence of CVD or cancer in the obese group. You do the same thing for those who are slim or those who are in the lean group, and then you calculate your relative risk. So for you to conduct a cohort study, why do you want, what are the indicators or indications of conducting a cohort study? First of all, there must be good evidence. You know, remember that you have to follow people over time and you spend a lot of money and all that. You must make sure that there's a good evidence of association between the two things you're looking at, the exposure and the disease. That means you must have done a case control before time. The case control tells you, yes, there's an association. The odds ratio will be high or low. Maybe it's protected, so it will be less than 1. But if it is more than 1, yes, and these two things are related, then you can now go ahead to do a case cohort study to see whether that disease will cause, that exposure will cause the disease. You don't want to go and start doing a cohort study for an association you don't even know whether it exists or not, and you spend all time and energy only for you to find out that there is no association. So for you to do a cohort study, there must be good evidence, scientific evidence of an association between the exposure of interest and the disease of interest using either your comparative cross-sectional study or you're using a case control study. And in doing a cohort study too, usually you use that, remember we say, is when you're looking at rare exposures. So the exposure has to be rare for you to use a cohort study because it takes more. If it's not rare, then you do other things. So exposure has to be rare. And then when the attrition among participants can be minimized, you don't want to start with a sample size of 100. And then by the time you're following them up, by the time you want to do the analysis, only 10 people are remaining. Your results will not be what's valid. So for things like that, you want to do a cohort of people who work together, or people who live together, or people who, so because people who work together, most likely, they will be in that organization for a long time. So that even if one or two people leave, it won't be, the difference won't be much, which is the reason why when you do your sample size, you need to see that you have to calculate loss to factor in loss to follow up when you're determining your sample size for prospective studies. Then you must have sufficient funds because cohort studies they take long. You have to follow people up over a long period of time. You have control groups, and then so it's actually capital intensive. So you must make sure that you have sufficient funds. It's not one, maybe for a study that you need to follow people up over 20 years. After the 5 years, you will lose your funding, or you don't have money enough or funds enough to complete it. You must ensure that before you start, you have sufficient funding for that duration of time that you need to do that study. There are different types of cohort study, depending on the outcome, whether the outcome has occurred at the start of the investigation. So for a cohort study, you can have a prospective cohort study, you can have a retrospective cohort study, then you can have a combination of the two. In a prospective cohort study, that's the follow-up study. It means the outcome has not occurred at the start of the investigation. So when you have those exposed to that factor and those not exposed, you follow them over time. That's a prospective cohort study. When you have what we call the retrospective cohort study, in the retrospective cohort study, also known as your historic cohort study or non-concurrent cohort study, the outcome has occurred at the start of the study. The outcome may have occurred in some people at the start of the study. So the investigator is going back in time many years to select his study group from existing record to now come down to find out, oh, those who were exposed, and then follow them up and see what proportion of them came down with the disease and those who did not come down with the disease. Then you have the combination of prospective and retrospective cohorts, where the cohort is identified from a past record, and then the same cohort is also being followed up for further assessment. A typical example is, let's use those cases of the nurses in the diagram that we saw below. They have the obese ones and the lean ones. So when you start at the beginning of the study, nobody has CBD, none of them had cancer. And then you follow them up to now find out those who have the disease and those who do not. That's a prospective cohort. So in a retrospective cohort, you now have those who have the disease. Some of them may have had the disease. So you go back in time. So these are, let's say they are nurses, they are nurses and they work in a particular place. So you come down, you find out those who have that either CBD or cancer. Then you go back to their record, because for them to be, maybe they've worked for 30 years or they've worked for 20 years, they've been nurses for 20 years. Then you go down to before they graduate, before maybe 20 years prior to that time, at the time when they were. So you can take a cohort of those who have graduated at about 20 years before that time. Among those people who graduated then, at that time, some of them were obese, some of them were lean. If you follow their records, and then come down to where we are now, you'll be able to get the incidence of those who have CVD or cancer among those who were obese, and then those who had CVD or colorectal cancer among those who were lean. When you calculate the incidence, then use that to get your relative risk. Now, in combination of prospective cohorts. So let's say the same people like today, now, you go back 20 years in time, find out those who were exposed and those who were not exposed. Follow them up to now. You find when you get to today, you keep following them up till maybe another 10, 20 years. So you're starting from before, prior to the time from the past record, and you're going beyond where you are. So what determines the direction or the name is where the researcher is. So at the time of the start of the study for a prospective cohort, the researcher is at that beginning, there are no diseases. The outcome hasn't happened. In the retrospective study, the outcome has happened. In a combination of retrospective and prospective, some outcome measures have happened, some have not. You just keep following the people up over time. So looking at this diagram, this is a prospective cohort. If you look at the start of the study, which is in green, I don't know why my pointer, okay, it's showing now. You can see the pointer. Can anybody see what I'm pointing at? Hello? Hello? Can I get a response?
We can hear you,
Okay,
ma'am.
can you see my pointer? There's a red light. It's faint. Maybe the battery is weak or something.
No.
No, ma,
Anyway,
we
the
are not
green
seeing it.
label where it says start of the study.
Yeah, we can
That
see start
green
of the study.
label is where sorry? That
Yes, we
green
can see
label,
the start
yes,
label. Yeah.
that's where the investigator or the researcher is. So at this point, you need to understand that the exposure of interest in these women is obesity or whether they are lean. The disease has not occurred. You're looking at maybe this is a study looking at determining heart attack in women. And you want to look at the exposure factor is their weight. So those who are obese and those who are not obese, nobody has had heart attack yet. Then you follow them up on that over time. So in this picture or the diagram where you have male and female, the ones that have the red dots are probably those who were obese. The ones that don't have are the ones who are lean. You follow them over time and then determine those. So the red human beings now on the right are those who have who have had heart attack. So when you calculate the incidence among those who were obese and then divided by the incidence among those who were lean, that will give you the relative risk. That will tell you whether if it is the relative risk is also interpreted like the cohort study. So for a prospective cohort, this beginning of the study, the diseases have not occurred. It's just the exposure of interest. Now, this is a picture of a retrospective cohort study. In a retrospective cohort study, see where the start of the study is. The start of the study is the end of, is like now. This is the end of, and then you have the outcomes may have already occurred in some of the subjects at the start of the study. So this represents a cohort study of employees of a tire manufacturing company. And they want to know whether the chemicals used in that tire manufacturing company increases the risk of death. So these ones, the ones that are red, the human beings that are red are the ones who already died. And you know that there are those who are there, some of them are exposed, some of them are not exposed. So when you, at this point, outcome measure, some people have already died, some people have not died. So you go back in time, go to the employee record and find out those when they were employed, after they have been employed. There are some people who work in the area where they work with the battery. And then you know there's some who are administrative staff. They don't have any business with the field or the factory or the job site where they deal with this chemical. They can be the control measures. Then you find out those people, then follow those two groups. Among those who work in that factory or in that part of the factory where they are exposed to the chemical, some of them may have died at the time of when the study started. Then you will get the incidence of deaths among those people. Or among the people who were working in administration, in the offices, they don't go to the sites. Some of them may also may have had heart attack. So when you calculate the risk, incidence of exposed over of those not exposed, it gives you a relative risk. So if more people died who work in the job sites where they are in contact with the chemical, as opposed to those who are in administration, then you can say that yes, exposure to this chemical can lead to lead to deaths among the workers. So looking at the start of the study, at the start of the study for a prospective cohort, the disease has not occurred. While at the start of the study of a retrospective cohort, the disease may have occurred in some people. Then for a combination of both, after the start of this study, for a retrospective study, it doesn't stop here. The study progresses beyond the start of the study. Just keep following them up. So it starts from behind and it's still going ahead. Okay, so basically, when you look at the prospective cohorts, exposure at the start of the study, you're assessing the exposure. The outcome, you follow up in future to determine the outcome. While in retrospective cohorts, it is assessed at some point in the past, but the disease has already occurred. So you see the investigator in the middle, which is supposed to be the start of the study. So the investigator is at the middle. When it goes before the outcome, it's retrospective. If it's after, but if it starts from before and it continues to the future, it's a combination of both study. So in a cohort study, like I said, what you are calculating is a relative risk. So by the time you have your AG over D, your relative risk, if it's equal to 0, then that exposure cannot cause that outcome measure. If it is greater than 1, then definitely that exposure causes that outcome. If it is less, it means being exposed to that thing will actually protect the someone from coming down with the outcome measure of interest. Okay, so basically that's what it looks at, your relative risk, incidence of exposed over incidence of those not exposed to the disease. Now, what are the steps in conducting a cohort study? You have to select your subjects. So you select your subjects just like you select your cases. So your subjects now are those who are exposed to the exposure factor, the controls are those who are not, and then you have to measure the exposure in both groups. So you have to also select your controls and make sure that they are comparable. And also match them. You follow them up, then you do your analysis and get what your relative risks will help you make that decision. So in selecting your the subject for your study, it can be from general population, which is the fairly frequent, when exposure is fairly frequent in the population. If it's something that exposure is common in that population, maybe something that is airborne or something, then you select, or you could select your study from special group, like professional groups. Like in the case of that, the study among for the nurses. So it's a professional group. You can do the one among doctors. It can be for those who are working in a particular place, a professional group. It can be a homogeneous population. So the advantage of using such special group is because they are that special group, they are usually, you can easily access them in one place. So it's easy for you to follow them up over a long period of time. And the exposure groups for rare exposures too, if you select a subgroup that have that in a factory or maybe in a workplace, it's easier for you to follow them up over time. And then in measuring the exposure, the information you can collect it from either the subject, like in the respondents or participants, you can ask them and collect the information from them. You can review their records, especially if you're looking at a retrospective cohort, medical information, the type of surgery, depending on what your objective is. It can also be the one that you need to measure, do a test, collect blood, check for the disease you're looking for. And then that's how you can measure your exposure. Or it can be an environmental survey. So there are various ways you can actually do your exposure measurement. And then your controls too. Your controls can be selected. Remember, we said we must match them to make sure they are comparable with your the study group. And there are different ways you can get your comparison group. You can have an internal comparison group. An internal comparison group means that both those who are exposed and those who are not, that your cohorts are compared within the particular group. Now, the only way you can do that is maybe if you're looking at something that is an exposure that is dose dependent. So among those, let's say in that chemical factory where you're checking for a tire factory where you're checking for chemical. Now, those dependent, maybe those who were exposed to that chemical in 1 year, you want to compare them with those who were exposed to that in 10 years or in 5 years and find out and said, oh, those is as if the more someone works in that place and is in that environment, the higher the chance of developing or even faster rate of developing that disease. So you can have an internal comparison group. And usually this kind of comparison group is even what you have in your nested case control. Then you have external comparison group where you have the two groups are mutually exclusive. So you can have maybe you're doing a study in a hospital and then something that had to do with x-rays. So you want to compare radiologists who work with the x-ray with ophthalmologists who don't, or general surgeons who are not exposed to the x-ray. So you have external comparison group. Or you can also use comparison group can also be from the general population. But for you to use a general population comparison group, it means the rate of the disease in general population in the same geographical area is used as a comparing rate to the exposed there. Then how do you do follow-up? Now, in your follow-up can be done as a periodic medical examination for each of the cohorts. So if you say every 2 weeks or every month, you go and measure or follow up both those in the study group and those in the control group and measure and see whether they have come down with the outcome of interest. It could also be reviewing records. So you review the record, you followed, maybe, like I said, 20 years ago, you had that information, their record from when they graduated from school, the nurses. You go back and check a year after graduation, what's their medical fitness like in terms of what's the state of their heart. Do they have CBD? Do they have cancer? After another 1 year, so you keep reviewing the record to check, and then you'll be able to determine at what point each person developed the disease for those who developed the disease or outcome of measure. So you can review hospital records. You can use surveillance of death records. You can use also ask questions or do interviews. You can mail questionnaires, you can use telephone calls, you can actually visit people in their homes. Why do we have loss to follow up? Because we say loss to follow up means, especially when you're doing a prospective study, you're following people up. Some people that you included in the study might not be there at the end of the study. So there are different reasons why some people will leave. Some may have migrated. We all know about the current Japa syndrome going on in Nigeria. So among healthcare workers. So if you have doing this thing among healthcare workers, and then you come back to collect, and then a couple of people have left the country. So they have migrated. Or people can change residence. You're doing something in River State, and then the person can move to another place or move from urban to rural area. It can also be change of occupation. Let's say you're doing that study when you're looking for checking the incidence of cancer of the lungs or whatever, blood cancers, comparing among radiologists and the general surgeons. Someone who's a radiologist can decide that, oh, I don't want to do this job again. I'm changing my profession. And then the person obviously will no longer be part of your study. So that can also be retirement. Yes, when people retire, especially if where you collect the data is in their office, in their job location, when you go there, you're not able to access them again because they may have they have retired from the organization. So they have no business coming back there. Even the exposure is no longer there because they are no longer in the organization. Some may also just no longer want to be part of the study. Remember, when you're collecting or getting informed consent, you say that people can decide at any point in time during the study that they no longer want to be part of the study, and they have a right to withdraw from the study. That is also another reason why people can leave the study. But so far, death is not the outcome of measure, because in some study, the outcome of measure might be death. So that person is still included in the study. But if it is not, then death can be a reason why people may no longer be part of the study. And so you have your strengths and your weaknesses. In a cohort study, remember, the exposure precedes the outcome, so you can calculate incidence. That is the number of new proportion of those who have the disease or new cases. And because there's temporality, exposure happens before outcome, you can establish a causal relationship between that exposure and the outcome measure. It's also very useful in investigating rare exposure. So when you have exposure that is not common, you're able to catch one or two people who have that. You want to follow them up over time to find out if they will develop the outcome of interest. And because you're following people over time, you might be able to study several diseases or more outcomes that can happen. So the person, if you know you're following the person up over to see if they have cancer of the lungs because of smoking, you might also end up seeing that there are other diseases, the other things that may also come down, they may also come down from. So this is an advantage for a cohort study. While in the case control is the other way around. It's a rare disease, and then you can study multiple exposures. In a cohort, is a rare exposure, and you can study multiple outcome measures. And it provides you with a direct estimate of a relative risk, and you can measure those dependent relationship, especially I gave you an example when you're doing using an internal comparative group, and there's less bias than what you have in the cohort study, because you're not asking them any question, especially the prospective cohort. You're just coming and measuring and following them up. They won't say they've forgotten, because they are currently still living out what you're measuring. The limitation is that it's unsuitable for rare diseases. With diseases that are very rare, it will be difficult for you to find the number of people that will be exposed to that factor for you to be, because you can get people at the end of the day, none of them will have that disease because it's rare. So for such diseases that are rare, it's better to use a case control, where you go from the cases to the exposure level. And it's very time consuming. Some diseases, depending on the latent period for that disease to manifest, can be as long as 20 to 30 years. And of course, you need funds, so that makes it pretty expensive. Things like loss to follow up, because people can migrate. You can't tell people because they're part of their study, they want to migrate, or they want to, they are no longer in, they can actually get tired, or they're looking for greener pastures. You can't tell them not to go. Sometimes too, funding can be an issue. The people, if you don't have the full funding before you started, or maybe you even have it, but because of inflation and all that, what you have is not enough, or the budget might not be able to cover it anymore, then sometimes too, even staff or the people that are helping you carry out the thing can even migrate themselves. And if you're doing a retrospective cohort study, if you don't have a complete data set, it's difficult, because you need to get information from the records may not be available. You can also have things like selection bias if you don't recruit, when those who are in the exposed group are significantly different from those who are in the control group. That will give you. And another bias also is what we call the Houghton effect, where, because people know they are being watched, they will obviously do the things that they expected to do, because they know they are watching them, so their behavior will be different. And core studies also prone to ethical issues, because a lot of times even though you're observing, but things you have to come in and measure some of those measurements and things you're measuring can actually be invasive. So this is a diagram of what just basically tells you what happens in a cohort type of study. You're going from exposure or not exposed to the outcome measure. So you're comparing the incidence. So your incidence of that disease, while in a case control, you're comparing prior exposure. The disease has already occurred. Then we have the experimental studies or intervention studies. They are the same thing. Experimental or intervention studies actually means that the researcher or the investigator is actually manipulating or instituting an intervention or a treatment or a training, a health education. You're making some manipulation or withholding some intervention from some people. So it's usually done it has to be in a prospective manner. Experimental studies or intervention studies are usually done in a prospective manner. And it differs from a cohort study in the sense that the investigator is in control of the intervention. It decides those who are in the intervention group and those who are not in the intervention group. In a case control study, the human beings that decide for themselves. I decide I'm already, this person is obese, so obviously he falls into this group. This person is lean, obviously he falls in the other group, unlike what you have in intervention or experimental study. Experimental studies involves an action, manipulation. There's a deliberate application or withdrawal of a particular, and one group has the intervention, the other group does not have the intervention. There are types of experimental studies or intervention study. They have the randomized control trial and the non-randomized control trial. So basically in one group, people are randomly allocated into intervention group and the control group. While in the non-randomized trial, people are not randomly allocated. The means of allocation is not through randomization per se. So there are steps in carrying out randomized control trial. In carrying out a randomized control trial, you must draw up your protocol. Your protocol is your procedure, your standard operating procedure that you want to use to carry out this study. It must be detailed, written down explicitly. You must select who your intervention group is and who or experiment group is and who your control or reference population is. They must be clearly stated. The eligibility criteria of what makes one in one group and the other person in the other group must be written and adhered to. And then you must randomize. You have to decide how, you must use randomization to allocate people into each group. So you can either use simple, depending on however, but in randomization, it just means that there's an equal chance of an individual or a subject being allocated to either the intervention group or the control group. And then you will now give the intervention to one group and then you follow them up over time, then assess the outcome of measure. So assuming it's a drug, you want to test the effectiveness of a drug against a placebo or a effectiveness of a new drug against an old one that is the standard of care. So you have to draw a protocol who meets that criteria to be included in the study, and then decide who your group, randomly allocate people who have that disease. Maybe there's a new drug for hypertension. So you have to have all the people in your study, obviously, will be people who have hypertension. Now you have to randomly allocate people into control group and intervention group. The intervention group will be people you're giving the new medication. The control group will be getting either the placebo or the old or the current standard of care. And then you follow them up over time. And the two groups must be comparable. And you follow them over time at the end of the day, you want to measure the blood pressure to find out whether the blood pressure is controlled better by the new drug as opposed to the placebo or old drug. That's basically the steps in doing your randomized control trial. So in doing your protocol and you must specify your aim and objective of the study. What is it you hope to achieve with that study? You must categorically state your inclusion and your exclusion criteria. You must have a sample size, which you must meet. Remember, if you don't meet your samples in whichever study, apart from the case report and case series, every other study needs a sample size calculation. And the sample size calculation is supposed to tell you is the minimum number of subjects you will have to include for the results of your study to be valid. So if you don't meet up your sample size, your result will not be valid. It's as good as not doing anything. If it's for your exam, maybe your defense, you've come for your defense and you calculate a sample size of 20 and you're using 19, that's where your exam will stop. You will go back and go back to the field. You'll come next year and repeat that project. So your sample size must be met. And then for your sample size to be met, I did mention, I'm sure when you're going to be taught how to calculate sample size, why you need to factor in non-response rate and then loss to follow-up or attrition rate. So you must specify what the sample size is for both groups. You must specify how you want to allocate the procedures in your group, in the study group and the control group. How do you want to give them that medication? How do you want to administer it? Is it in the morning? Is it in the night? Is it 1 tablet? Is it 2 tablets? What is the treatment and its modality? How do you want to provide that treatment? Well, you have to standardize the working procedure. So whatever you do to A, you have to do it to B. So if you're giving the new medication by 6 p.m. amongst the intervention group, for the control group, you must give that placebo by 6 p.m. too. So that they will not, because people, depending on the kind of blinding you're doing, may not even know which group they belong to. And that helps to make your results valid. You must also specify the responsibility of the parties involved in the investigation or in the study. What are the people in the control group supposed to do? What are people in the experimental or intervention group? You as the investigator or the primary investigator, what is your job? What are the research assistants that you recruited to help you do the study? Everybody must know what they are supposed to. Clear responsibility must be clearly spelled out and documented. Then you must strictly adhere to that protocol, to the standard protocol that you have set up. The protocol you have drawn up must be strictly adhered to at the same time for both groups. It's not because you want the intervention group, the new drug to be, you now pay more attention, sticking to the time, measuring those groups more than you measure the control group. No, if you measure the intervention group 3 times a day, blood pressure, you must do the same thing to the control group. And you must prevent bias to reduce error in your calculation or in doing your protocol. So zooming, this is the diagram of depicting doing an ROCT with a new drug or a placebo. So you have patients ab initio, meaning assuming is antihypertensive. So all the patients must be hypertensive. You can't get somebody who doesn't have hypertension to include in this study. No, you're not going to be able to do that. That's why you use randomized to test hypothesis. You can't do prevalence of a disease in RCT. So everybody must have hypertension. Then you include them in the study. Then you randomize, by randomization, you allocate those in the control group and those in the treatment group. And I have equal numbers and administer your intervention, follow them up and measure your outcome of interest in both groups. So what's randomization? Randomization usually, like I have virtually said what that is, process of allocating participants into the different groups they belong in. And the whole essence is it tries to remove, reduce, or eliminate bias and allow that both groups will be comparable, so that even if there are some people who have blood pressure that be controlled, it can be in both groups. It's not only in one group. And so what matching does for you in matching helps you to control for confounders in a case control study, while randomization attempts to take care of whether the confounders that you know and the ones you don't know, you're equally distributing them across the two groups. So whatever the confounder is in A can also be in B, and so that kind of crosses out. Randomization is the heart. That's the main distinguishing factor of an RCT or a controlled trial. And investigators have no control over those who are allocated in the control group and those who are allocated in the intervention group. So each individual that is or subject that is being included has a known and equal chance of being allocated to either group. In RCT2, you follow them up. So in a follow-up examination of both intervention groups and the control groups at a specified interval must be done, irrespective of which of the group they belong to. I explained that earlier. And then the intensity that you use to do the measurement should be the same in both groups. If not, it will introduce bias. The people in one group might know what is going on. And so the circumstances, the timing, the time frame, the final assessment is the same measure you have to use for both groups as you're following them up. And follow-up may be short, it may take years, depending on the outcome of interest. So if it's something like blood pressure, in the anti-hypertensive and blood, in a couple of days, weeks, you may be able to get your outcome measure. If it is something like development of or something, depending on the duration that thing it will take for that outcome measure to manifest, to determine the length of your follow-up. So loss to follow-up may occur due to different reasons that we have mentioned. So in RCT, there are different sources of bias. There are certain types of bias that you have in ICT. Remember the sampling and the selection, those ones have been controlled by doing your randomization. So, but you still have things like participant bias. Participant bias is the type of bias whereby the individuals who are in the intervention group, who are getting the new drugs, they know. So they might be self-reporting more improvements because they know they are getting the new treatments. So that is the type of bias. While on the other, observer bias now is where the investigator, because they know those who are in the intervention group, those who are getting the new medication and those who are getting the old one or placebo, they might want to pay more attention, or decide to put those who their blood pressure is already being controlled well. You put them among the people that will be in the group with the new medication, while the other control group will be those who already don't have good blood pressure control, or it might be the other way around, depending on what it is they're trying to prove. So the observer is biased because they know who is in one group. And then evaluation bias, the investigator may subconsciously give a favorable report to outcome. So in this, the person who is doing the analysis know those in the intervention group and those in the control group. So subconsciously, may analyze it in such a way that the result looks better. Excuse me, among those in the control group compared to those in the intervention group. And for this bias to be corrected, we correct it or we control it by something we call known as what's blinding and not randomization. You completely blinding. Blinding is usually when you don't know the people who are in any group. So you can have single, double, or triple blinding. In single blinding, the participants themselves don't know which group they belong to. They don't know whether they are taking the new drug or the old one. The and so that's corrects the participant bias. In the double blinding bias corrects the observer bias. In double blinding, the observer, the investigator, does not know which group the people belong to. He just knows that people in group A are taking this, people in group, but he doesn't know who is in group A. He doesn't know who those is in group B. So he's blinded. Then the triple blind is where both the participant, the investigator, and the data analysts are blinded. They don't know, are not aware of who is in which group. So single blind is the participants. The double blind is both participants and the observer. The triple blind is the participants, observer, and the analyst are not aware of which group, who belongs to which group. And when this is done, actually results that are triple blinded actually has more validity than the ones people know who and who is in the different groups. Then we have the non-randomized trials. The non-randomized trials are they are not randomized. People are not allocated based on 1 minute, please. Then in non-randomized trial, there's no, by the name, of course, there's no randomization. And because people are not randomized, the degree of comparability between the two groups is not the same, because people already can't control a lot of things. So there are types of uncontrolled trials, types of non-randomized trial. You have the uncontrolled trials. In where you don't have control groups. You have some quasi-experimental without control groups. Then you have the natural experiment. The natural experiment basically where you have the event or the intervention, the people are being of interest. They are not being manipulated by the researcher. So it's just something that occurs naturally. It's rare for variations in exposure to such interventions to be random. So they just kind of occur, and then there are you just basically things you do. A typical example is maybe you want to check the impact of at a population level, maybe the impact of a policy in a population on a particular health outcome or in a health inequality. Just observing the natural environment. You don't have any, look at this group compared to this group, you're not exactly manipulating. Then you have what we call the before and after study. Before and after, some also call it the before and after quasi-experimental study with control groups, or before and after. So you have the individual can serve as their own control when you don't have a control group. When you have a control group, so you have two groups. What happens is that before the administration of the intervention, you do a baseline study. Start doing that baseline study, you now administer the intervention. Then you come back after a certain or specified duration of time at which you expect that the effect of the intervention would have been seen. So you come back and do another cross-sectional study or another baseline, and then compare the result before and the after, whether there's any change. Did things get better? Did they not get better? Is there no change? That's the before and after. Then you have something we call the crossover design. In crossover design is a type of design you usually see in clinical trials where the participants maybe received 2 or more type of treatments in sequence, but in different order, so that you're assessing the effect of that medication or each of the medication in the same individual. So one individual is serving as both the intervention and control group. So let's say there's drug A and drug B. So you have two groups. So the first group, they first give them drug A. The group B, they first give them drug B. Then you wait for a period of time called the washout group. Then you come back. That group, the first group that you gave drug A, you now give them drug B. The second group, you gave drug B first, you give them drug A. Then after you do your analysis and then determine the effects of. So usually what happens is that you want to give that first medication. If let's say it's a blood pressure medication, you want to give that medication type first treatment to an individual, and then after a while you check the blood pressure. If it's being controlled or if it is not, then you stop. You give a washout period, a period at which you expect the effect of that antihypertensive to clear from the system. Then you now come back and then give the drug B in the same individual and see whether that same drug can also control the blood pressure, or how much better it can be in controlling the blood pressure. The same thing is done in the two. So each individual serves as a control for the thing, and then you can also check it across. And then the wash period, there needs to be a period, must be a period where that person doesn't get that investigation. But sometimes it can be challenging to manage. You can also have some ethical issues in terms of, somebody is hypertensive, you've given them medication, then you now leave the person for a period of time without giving them medication because you want to come and do another experiment. Then in a single arm study. In the single arm study is what we usually see in drug trials, in phase 1 and phase 2, when they first bring that medication or that intervention. The first phase 1 and phase 2, you're looking at determining how effective, and then their pharmacological effect and the side effects of that study. Basically that's what it is. And so you have your advantages of cross-section, the crossover designs. You can reduce individual variability because it's the same person you're using for giving both drugs. And then they are less susceptible to confounding factors because it's the same factors that were there from beginning in an individual is still there after. And they give you more precise estimate of your treatment effect. Disadvantages because of the crossover effect. Sometimes the effect of the first medication may not completely wear off. So it might still linger for a while. So when you're giving the second one, you cannot exactly say that is whatever result you're seeing is because of the effect of the second medication. And because I've talked about the washout period, how you just leave somebody that needs a medication because you're waiting for the medication to wash out. And there's potential for bias for this because the patients who bias in terms of patients may comply more when they are taking a particular, where they are maybe less likely to complete the study if they have to receive multiple treatments. It's as if they're just doing trial luck with us. At some point, maybe by the time they're taking the second medication, they are tired and they don't want to be part of the study anymore. So that's just that. So basically, we've talked about different study designs, how it can be descriptive or analytical, and which belongs to which group. And then we looked at the quality of evidence in terms of hierarchy, the strengths. Hierarchy of the quality of evidence is determined by the study designs that are being done. So I don't know if we have any questions. Any questions? Any questions? Our time is. Can we have some questions, please? Or contribution? Hello?
Yes, ma'am. Please, I have a question.
Go ahead, please.
Please, can you clarify the major difference between a retrospective cohort study and a case
control? So remember I said, I can't hear you anymore, but I believe you're asking the difference between a case control and a retrospective cohort. The first thing first is that we know that a case control, you're looking at the disease. That is your concern. In a cohort study, you're looking at the exposure. You're looking at what is of interest to you is the exposure and not the disease. So in a case control, the disease have happened and is used for rare diseases. This disease has occurred, and then you now select those who don't have the disease. And then you go back in time to find out whether they are exposed to that, the factor of interest. In a retrospective cohort, let me find the diagram, maybe that, like in a retrospective cohort study, the outcome may have occurred already in some subjects. In a cohort study, your interest is the exposure status, and then you're following them out to determine the outcome measure. While in case control, your interest is the cases, and then somebody in a retrospective cohort, now you want to find out, because most times the duration, the latent period is long. So you don't have the resources and the time to do that. So some of the diseases or the outcome measure may have happened. You're going back in time, but even when you go back in time, you're going to start from where a group is exposed, a group is not exposed. And then you follow them up in the record per se. Because you're going to calculate incidence. Because if you go back 20 years, after 1 year, you have to check how many people have developed this are dead from this chemical. After 1 year, you check again. In year 2, you check again, because you calculate incidence of the disease or the outcome measure in both exposed and unexposed. In case control, you don't even know when what happened. What you're just doing is you get your cases, you get your control. Were they exposed? Were they not exposed? But your interest starts with the cases, the disease, the outcome measure. In a cohort generally, your interest is the exposure. But given that sometimes it's difficult, is not possible because of the cost and the duration, there's some kind of modification that was done to bring in the retrospective arm, where you can still go back after you've seen some who have the disease and some who don't have, who may not have the outcome, and go back and see those who were exposed and those. So in the year 2, you might have incidents to be 2/100, assuming those who have the disease were 100. 2 over. So you're looking at, remember this diagram I gave you. This is looking at what? Exposure and non-exposure for cohorts. That's where you're calculating your relative risk across incidents, incidents of those in exposed and those not exposed. While in the case control, what you're looking at is disease, the odds in the disease versus, or in the exposed versus odds in those who are not exposed. So depending on what is your concern, if it's a rare disease that you're dealing with, you should know that definitely is a cohort that you would, a case control that you would do. If it's a if it's a rare exposure, is a cohort study that you would do. But because cohort studies are usually long, to save that time that you would lose when you're following people up, a retrospective cohort can help you to get that. I don't know if that makes it clearer. So the timing, we are doing the, hello?
Yes, ma.
Sorry. Okay, any other contributions or questions?
Hello, can you hear me,
Hello?
ma?
Hello?
Yes, ma. I have a question, please.
Okay, please go ahead.
Yeah. What if in a situation this question goes to descriptive and analytic study. That is for the observational. What if a situation where one have an element of uh analytic and also descriptive?
An
What would the
element of
person
both.
call it? The
That's why I said
analytic.
when you have something like that, there's no point trying to qualify whether, just write it as a cross-sectional study.
Translation.
That's what you just leave. But some people, some school, because there are different school of thoughts, and some people don't believe that there's anything called analytical cross-sectional study. So when you just write it as cross-sectional study, but if you have a supervisor that insists that you should write it as,
Exactly.
you're
Exactly.
going for an exam, just write it because your supervisor asked you to write it like that. You might go to the exam and the examiner is of the school of thought that said, no, there's nothing like that this is not a purely descriptive study. At that point, all you will say like, okay, no problem. You will take notes. You're not arguing. You're not an authority yet, but nobody can fail you because you wrote descriptive cross-sectional or analytical cross-sectional studies. One of those things that are still being, there are different school of thought talking about it, but to be on the safe side, just write cross-sectional study. If you are asked to do this, just quietly accept, okay, no problem, sir. I would include that. An examiner said, no, you don't want that. You take it out at any point in time, whoever you're with. When you're done, you can now come out. By the time you understand, you now go, oops, sorry. Okay. So your best bet is to just write it as cross-sectional study, or is a comparative cross-sectional study, or is just a cross-sectional study.
Okay.
All right. Any other question? Any other person?
Yes, ma. Good evening, ma.
Okay.
Okay, ma. When
Go
you
ahead,
mentioned,
please.
okay, ma. When you mentioned non-concurrent cohort, so I was expecting to hear the concurrent one. I don't think.
Concurrent. I didn't say
Yes.
concurrent cohort study.
You mentioned non-concurrent, so I was thinking maybe you
Not
also
I. With what regard? What do you mean by non-concurrent cohort study?
non for the yes, for the non-concurrent, that is mention it as a historical cohort study, which is also non-concurrent.
Okay, that's your retrospective cohort study now.
Yes, you also mentioned it as historical and non-concurrent.
Some
I
call
think
it, yes, some call it that, yes.
okay.
Because it's looking at history, something that has happened. Yeah, go ahead.
Yes, ma. So I was expecting to hear maybe the concurrent aspect of it, but you didn't mention that. So I don't know if you can
There's
throw more
nothing,
light.
you just have prospective, the one you're following up. And then retrospective, you're looking back. It doesn't mean that since you have the prospective, retrospective, and a combination of both. So I haven't seen anywhere where they wrote concurrent cohorts. Even the non-concurrent, it's just some people that call it non-concurrent, some call it, but what is universally accepted or called is retrospective cohorts, prospective cohorts, or you have a combination of both.
Okay, ma. Thank you.
Any other question, please? Any other question? If not, I think we won't spend, our time is fast spent. Well, let me check the chat box. Sorry. Okay, there are no questions in the chat box. All right. In the absence of any other questions, so we can call it a day. But if you have any questions, I can still take a bit of a time to, even though our time is gone, I hope you don't sign us out.
Okay, ma. Good evening, ma.
Okay, so we can call it a day since we don't have any other questions or contribution. Okay. Good night, and then have a great, the rest of your day.
Good night, ma. Thank you.
All right. Bye.
Good night, all. Good night, man.
Good night.